I just wanted to say thanks to Claude and Mary for inviting me, and just to say that, you know, what I'm going to share with you is just my own experience, my own thoughts of working with industry over many years, many years, and I am passionate about palliative care. I'm passionate about, you know, the person that we have the privilege to care for, and I am really pleased that over the years industry has engaged with me and many other people like me in improving care. So I'm just going to talk a little bit about my background, because I think as a clinician and as a researcher, that does influence, you know, our subjects and our focus. I do want to obviously talk about how I have worked with industry over the years, how I got involved as a clinician, and I'm going to talk a bit about one example of research with industry. So if we go along. So just to say I suppose my background into palliative care was an interesting one, and one I'm very grateful for. So just to say, prior to coming into nursing, I was a priest. I worked in Mount Argus. I lived and studied and worked in Mount Argus, which is just up the road from Our Lady's Hospice in Dublin. And in 1981, which is a good number of years ago, I used to go to Our Lady's Hospice in Dublin. A lot of it, the newer part, hadn't been built at that stage. And I used to go down on a Saturday morning, and I used to lend a hand with the nurses there, particularly in the nurses. There was only one doctor at that stage, but it was mostly very much nursing led, and I used to work as a voluntary healthcare assistant. And that's where I really learned about the essentials of palliative care. And I mean by that, you know, being able to wash somebody, to dress somebody with dignity and respect, to maybe help somebody with a bit of food and drink. And probably the most important thing I learned in those days was how to listen, you know, and I heard a lot of stories that I've never forgotten, but, you know, really sometimes, you know, to listen and to learn, I think. And during that time I did, that was my first entry into a little bit of education, where I went and did a little certificate in the care of the dying in St Gemma's Hospice in Leeds. And then 1989, a couple of years after I was ordained a priest, I was invited back to be the pastoral care lead for Our Lady's Hospice. And I had the privilege of working with many great nurses and doctors. And some of you may know Michael Carney, who was a clinical director at the time. He's over in America now. But also I was very much seen as part of the multi-professional team as the chaplain. And you know, I've often thought about that since. So that might help the background. Like all wise people, I thought there wasn't a lot of money to be made in priesthood. So I thought about what other job could I do that could bring in a bit of money. Joking aside, you know, I realized that that way of life was not for me, but I realized there was a lot of what I did as a priest I enjoyed, and I looked around for a career that I could bring forward quite, you know, some of those insights and that listening and learning that I spoke about. So I took myself off to London in 1993 and undertook my nursing studies at the University College of London. And for the last, God, how many years, I've been a nurse working in oncology, hematology, palliative and supportive care. And most of that work has been in London, Surrey, and over the last 3 years in Belfast. And I've had the opportunity to work in many clinical roles, so some of them there, clinical nurse specialist, consultant nurse. I was the clinical lead for end-of-life care in a couple of the London hospitals, Chelsea, Westminster and Bart's NHS Trust. I've also held a number of leadership roles, including Director of Nursing. But in all of that time, I've had an interest in research in advanced disease. I've had visiting lecture and senior lecture roles, and I've always held those. And as I say, 3 years ago, I came to Queen's as a senior lecturer, and I'm the lead for equality, diversity, inclusion, and justice there. I'm very interested in that subject. And I've recently taken on the chair of staff development. I also think it's worth saying that during that time, I've always been involved in national and European organizations. So, you know, I obviously became a part of the research network in hospice and palliative care. I'm also a member of the Global Power of Oncology Nurses, a global group, European groups, and also I'm a member of Hematology Association of Ireland. So I've been involved in a lot of these groups, and in all of these groups, I've had an opportunity to work with industry. And to be honest, a lot of the work we've done, we wouldn't have achieved if we weren't working alongside our industry partners. I just want to say a little bit, it's probably no surprise when you see my background in the hospice and what drove me into nursing, that my first journey into research was looking at, I suppose, search for meaning, Viktor Frankl, or spirituality. My first piece of work was looking at an exploration of nurses' experiences of supporting a person with cancer in the search for meaning. And I must say that piece of research attracted a lot of interest among doctors and nurses and people across Europe and indeed across the world. And I remember having many conversations with doctors saying, you know, would you not consider, you know, doing something similar with doctors and their experiences of supporting a person with cancer and their search for meaning. So anyway, after a few years, I decided to go back, and I've been always full-time clinician doing my MSc and my PhD. So I did my PhD part-time at King's College in London. And again, I went back to this idea of, you know, sense making. So exploring, you know, how do people living with cancer make sense of that experience in all its components? And I mean by that, the physical, the social, the emotional, and spiritual. Now, you might say to, you know, if I said to you, you know, do you think a pharmaceutical company would sponsor or support a research study that was looking at an aspect of spirituality? You would think no chance. But in fact, they did, and I'm going to give an example of that now. So this is a piece of research that I will present to you in a few slides later. So this is looking at advanced cancer pain and a conversation tool that we developed and how we evaluate it. So I'll come back to that in a moment. I just wanted to say that, you know, as there are many clinicians, you know, and I mean that in the widest sense. So whether you're a doctor, a nurse, a pharmacist, a physiotherapist, a chaplain, or occupational therapist, social worker, counselor, but we are all guided by our own codes of practice. But I think what is really wonderful over the years is, you know, to actually work alongside industry who also have their own code of practice. And actually, if you look at this is the British pharmaceutical industry, and there'll be similar one for the whole of Ireland, but this is the one I'm more used to working with. But actually, if you look at their code of practice, it's not very dissimilar to our own codes of practices. So it is about, so the commitment you can see on the left there is about, you know, focus very much on patients or persons. It's about acting with integrity. We maybe use the words respect and dignity. It talks about promoting transparency and treating everyone with respect. So I think this is really important, and this has changed over the years. So when I first got involved working with industry, to be honest, there were practices that maybe industry were involved in, and in truth, professionals, healthcare professionals were involved, where, you know, probably needed to be tidied up, and they have been tidied up. So I think if you're going to work with industry, be assured that their code of practice will conform to our code of practice. They will be protecting the person who's the focus of it all, the person in need, just as our codes of practice will protect the person in need. And we can talk about that. So probably my first journey into working with industry was in the late 1990s. And at that time, I was the president of the European Blood and Marrow Transplant Society Nursing Group. And as part of that role, I sat on the board of this group. And this was a European organization that many of you know about, where we had, you know, thousands of people coming from all over the world to a conference which could not have gone ahead without sponsorship from industry. And equally, behind this board and behind this conference were multiple studies going on across the world. And again, most of those studies were sponsored by industry. So that was probably my first experience of beginning to work with industry. And over the years, these are just some of the things that I have done and continue to do, but it is, I've held a number of clinical conferences and webinars and study days. So, for example, at the Royal Marsden, we had regular conferences supported by industry. Now, the interesting thing is that industry really wants multiple sponsors. I think they're less keen to support research, which, where they stand alone, unless it's something they have thought of themselves. But when it comes to sponsorship of research, you'll find that industry is very keen that you also involve a number of different companies. So when it comes to clinical guidance, I have worked with colleagues from across Europe to develop oral care guidance in cancer and in advanced disease and in older persons. And these are just some of the companies that we work with. But I've also been involved with, with clinical colleagues across Europe, developing clinical guidance around pain management. I'll speak a wee bit more about this. I've been involved in a number of research studies, but I wanted just to give some examples. Again, these are ones that I have taken some sort of lead role. So I've been either one of the leads or I've been the chief investigator for. So oral care with Amgen, advanced cancer pain with Amgen, and I've been an important part, or I had an important role to play in a study with Amgen looking at communication in multiple myeloma. And I'm also working with my colleague Anya, who we are looking at new ways of working, particularly how do we support primary care doctors, nurses, and pharmacists to support people living with advanced cancer. So that's a nice piece of work that's coming off. So quite a bit of research, but other opportunities to provide education, training, clinical guidance, and looking at service delivery. So these are some of the current projects I'm involved in, and all of these websites have been sponsored by industry. They don't have any say in what goes on to, it's just to be clear, they do not have any say in what goes into the guidance. They don't have any say in what goes into the study day. They don't have any say into what goes on to these websites, but they are an important partner. So many of these, some of these groups go back 15 years plus. And some of them are national, i.e. UK, but some of them are European as well. So I wanted to talk about a particular piece of work research, and hopefully this is helpful. So where we work with industry. So this is the faculty. So these were colleagues I'd worked with in the past. And of course, and I've separated industry. So we did have somebody like Anya working with us, but they very much didn't want to be and saw themselves as not part of the faculty, although they had a science background. And this was a group of people from across Europe who really wanted to explore how do we better support people with advanced cancer. Now, this is within and beyond palliative care. So thinking of how do we support oncologists, particularly, and hematologists in supporting people with advanced cancer. Now, just to say that, in any partnership, there has to be a win-win for different partners. So those of you will know that Amgen have a drug, which is a bone-modifying agent, dacusumab or Oxiva. And of course, so they have an interest in raising the profile of better pain management. So there is that awareness. But as I say, that's just in the background, but the guidance is developed without any of their input. So why did we look at this? Why did we want to look at this advanced cancer pain together? So as you know, and I know palliative care is much wider than cancer, and that's great. And I've certainly seen that change since the 1980s. And who comes to the hospice, who comes into palliative and supportive care, who's getting that care. I think we have some more work to do around older persons and people with dementia, but that's for another day. But still, let's say this piece of work started in about 2016, 17. But pain, even today, is a symptom that is often associated with cancer. And it is also a symptom that brings a lot of fear for people living with cancer. And when we mean by pain here, of course, there's a lot of focus physically for pain, but in my mind, I'm thinking of the social, emotional, spiritual. And again, if you look at my background all those years ago in the hospice and what I learned there. It's interesting that, outside maybe palliative and supportive care, or even within palliative and supportive care, pain management still remains a challenge. And sadly, for a lot of people, pain is still underreported and misunderstood and often undertreated. And this underreporting or misunderstanding is both from the healthcare professional's point of view, but also from the patient's point of view. And again, I'll come back to that in a moment. And as you know, that pain never sits in isolation, but alongside that you have fatigue, sleep disturbance, and loss of appetite. But maybe these more harder to measure emotional aspects of anxiety, depression, isolation, or feeling alone. But we recognize that while there were many guidelines that existed, very few related to the management of cancer or advanced cancer pain, and certainly there was very limited when it came to holistic pain management. So we thought we'd like to do something about that. So we started off, we wanted a training resource that could be used by clinical staff, whether they were hospital or community-based, to support people with advanced cancer who experience pain. We wanted it to be a quick reference guide that is highly practical for practice. And we also wanted it, that if somebody living with cancer or family picked it up, they would also understand what this was about. And I'm really pleased to say that this has been translated into French and German and is freely available. And I mentioned the website. So just to say again, and behind all of this, there is an industry who's supporting us every step of the way. So this is something from one of the examples that we were trying to get at. It is linked to Michael Carney's work. But the idea is, whenever we come across anybody with a symptom, in this case, pain, in our initial observation or assessment, we only see a small piece of the puzzle. So this is like the iceberg above the water. But actually, if we really want to manage that symptom, whether it's pain, we need to be aware of the emotional, social, spiritual, and physical component of that symptom, but how that symptom can actually affect the person emotionally, socially, spiritually, and physically. So it does take more time, and that's what Michael Carney and many people in palliative and supportive care would recognize, that element of time. We also wanted to come up with, this sort of emerged from our work, this faculty group, was looking at maybe a more human approach to symptom management. So maybe recognizing and valuing the medical approach, looking at something a little bit more humanistic in its approach. And in this way, so again, we're talking about pain here, but this could be applied to any symptom where, the symptom is some sign of a disruption or a disturbance in a key relationship. So for example, physical pain is a disturbance or a disruption in the relationship between the person and their body. So behind that could be a tumor, it could be a side effect of treatment, whatever that might be. And then accordingly, social pain is a disruption or a disturbance in a key relationship between the person and their own world, in this case, their family, their work and society. Emotional pain is a disturbance or disruption in that relationship between how they see themselves, their own emotions, and in their relations with others. And spiritual pain is a disturbance or a disruption in a relationship between the person and their beliefs and values. Now, I think even today in 2023, we have come some way in addressing the physical, the social, emotional, certainly in palliative care, but I still think many palliative care doctors and physicians will shy away from this idea of spiritual pain. So again, and yet we as a faculty would be saying, unless we are willing to engage with it in some way, perhaps we will never achieve the pain management that we want. And again, I break at the beginning of this talk, I said to you where I was coming from. So again, but like all research, our ideas come from our own lived experience of life and of practice. So a part of this was we developed what we called a conversational tool. Now, please note, this is not an assessment tool because there are so many of these around, but we wanted to try and find a way that might help open doors into some of these more nebulous or more difficult conversations around pain. We wanted to open the door not only to the doctor or the nurse or the physiotherapist or pharmacist, but also to the individual living with advanced disease or their family. And so we created this tool very much with our faculty, but with people living with advanced cancer. So these are their words that they came up with and agreed to. But for example, there's some of the words around pain management like numbness or uncontrolled or gnawing or ache. These are the words we would expect to see. But also we were thinking about that below the water edge expressions of pain, like, for example, exhaustion, frightened, helpless, worried, isolated. So these more hidden words, and these words were carefully correlated with the idea of physical, emotional, social, and spiritual pain. So of course, we had developed this tool and all of this with the support of industry in the background, but actually we didn't know whether this tool was of any use at all. So what we did is we went back to industry and we looked for support for a research study, looking at the benefits of this tool. And some of this I could have predicted myself. I was the chief investigator, but let's go through it. But we wanted to look at evaluating this tool in practice. And it was a multi-site approach. We had 2 sites in the United Kingdom. We had one in France and one in Germany. So a lot of work, and as to say, we had industry behind us. So the design of the study was a pre and post study approach. So what we wanted to do, the study participants were either individuals with advanced cancer and their HCPs. So their healthcare professional could be a pharmacist, it could be a physio, it could be a doctor, it could be a nurse. And the study involved completing 2 study visits, which were coincided with their own routine face-to-face consultation. Now, just to say, this study started to be delivered, the fieldwork started to be delivered just as COVID was emerging. And you can imagine, those of you who've been involved in research at that time, it was very much a challenge. So in the first study visit, it was conducted as per usual, but at the second study visit, we used the MAP conversation tool. So this was given to the patient before they went into the clinic to underline or to circle 3 words that best describe their pain. That was what they were guided. So just what 3 words there would best describe your pain at this moment or in the last week. And so the individuals with advanced cancer and their HCPs independently completed questionnaires before and after these 2 visits. Now, just to say, sort of obvious in a way, it was essential that the individuals who completed both visits that the visits were completed with the same HCP to try and reduce any variance. And it was important that there wasn't too much of a gap between the first visit and the second visit. But you can imagine that a lot of these face-to-face consultations began to disappear with COVID. So the results were that we were only able to complete 27 people, 21 with people living with cancer and 6 HCPs, but we got some interesting things came out of this. So overall, both individuals, people living with advanced cancer and their HCPs, were satisfied with the communication during both consultations. And this is interesting because I've been involved in another European study where there was definitely a difference between what people with cancer were describing in the consultation and what the HCPs were describing were slightly different. But in this case, small numbers, but there was a consensus that this was satisfied with communication. I think what was really interesting, when it came to circling 3 words, well, the first thing would be unexpected was that the main pain descriptors related to some form of physical pain, so 95.2%. But that was closely followed by emotional, and I think which is surprising, and this is which I think is often forgotten, that over a quarter of the words circled were either social or spiritual. So this is an element I think that still needs a lot more work. But it gives you a sense that maybe the tool was beginning to open some important doors. And interesting that the individuals with advanced cancer, so the 21 individuals, said that they found the tool useful because it helped them to describe their pain. However, the HCPs found the tool difficult to incorporate into their consultations. Now, I could make a hypothesis. Certainly, this was due to time, but also we were getting people from an oncology background. So these were oncologists, nurses, and physiotherapists who maybe were less comfortable outside the medical model, which this tool was asking them to engage with. So overall, the research conclusion showed that, of course, the pandemic devastated the study, as I'm sure many of you have experienced. And of course, this study would not, unfortunately, have been seen as a priority by some of those 4 centres during the COVID. But it did give us a sense that the study, that we do need to consider these various aspects of cancer pain. And this resulted in a peer review article, publication in pain management back in 2021. So you can see now, I started off with the whole idea of spirituality. And then I asked you, would pharmacy, or would a pharmaceutical company have any interest in sponsoring a research study in advanced disease that had a spiritual component? And the answer is yes. And I think the key is communication and networking, really important. So we still have the guidance available. It's freely available, as I say, in French, German, and English. The website is still running, supported by industry, and the conversation tool is still available. But in summary, so I would really, and hopefully we'll have our conversation together, but there is a real opportunity for collaboration with industry as a positive way forward, being assured that we have professional guidance from our own profession, but also among the industry itself. Collaboration with industry can certainly support person-centered care. And I've given you one example. I didn't go into oral care, but I've given you one example where collaboration with industry can play a key role in improving symptom management, particularly in advanced disease.